Yes, and you're looking at her. But it's Spigelian line. And you must remember this line, man. No? Okay, so what is the Spigelian line, class?
The semilunar. That's
giving them another line.
Anterior is the canal, the lateral aspect of the
Somebody said something there.
the upward
Right. The lateral border of your rectus abdominis muscle.
not that what you said.
That parents tremble curve, yeah? It's a Spigelian line, yeah? And there's another thing we call the arcuate fold.
Oh my God.
That
Let's worry about the hair.
is a gentleman over there that is not so good in. We over there, the red dot, is the red dot is the man or guy?
Yeah, it's like a,
What's the arcuate fold of Douglas above? Huh? Not you know, so the guys that didn't further behind you. Yeah. So you guys don't know yet, man?
No.
You guys up here tell them what the arcuate Douglas is about. What's the arcuate fold of Douglas about? Yeah? You guys have any opinion on this one? That's the arcuate fold of Douglas about.
It's like this where the abs are lining, where the abs lining. Like,
It's halfway between the pubic symphysis and
What is the line about first?
the umbilical
along the
line.
linear alba.
Or the not paying attention to him, right?
Is it,
Martin didn't come here, man. I don't remember seeing him in the way.
sir, is it the line that goes between the umbilical region and the pubic?
But what happened there? You have to tell me express yourself.
is to transition with the fascia.
I'm sorry, the brain is rusty. Can't help me with
Okay,
that.
that's after the posterior rectus sheath. What happened there, sir?
There is no longer a posterior sheath.
There's no longer posterior sheath over there. So what happens?
The fascia is only formed by a single nerve.
that's like
Okay, the posterior is deficient, not rather deficient. All those layers that would form posterior now goes into the anterior aspect, yeah?
Sure.
And commonly, especially you ladies, at that junction, yeah, with the Spigelian line, there's a point called the Spigelian point. And what happens then how you ladies there?
herniation.
Huh?
Herniation.
Right, the hernia tends to happen there. And what's the name of that hernia? Miss Rary, what is the name of that hernia?
Spigelian.
Miss Rary? She knows who I'm speaking. Miss Rary. That's why they bring up, I mentioned the word Spigelian. Because that point is a Spigelian point, and commonly, ventral anterior abdominal wall hernia first. It's called the Spigelian hernia. Understand? What happens there? Okay? Especially you ladies. Okay?
Umbilical and pubic symphysis.
So below the arcuate line, or arcuate full of doors, where you think the creator didn't have a posterior aspect of the rectus sheath there. The criticism and he didn't do things without the paresis of things, you know? Don't must oscillate while you do that.
Allow the passage of structures. Allow the passage of structures that are even.
Okay, I will look at it from a surgical point of view. Sometimes they have in real life multiple say gunshot and other injuries to the tummy. And it takes several hours to operate. And during this time all of the intestines become edematous, etc., etc. So when we have to close this linear alba, yeah, you heard about the linear alba. Where else in the body, you know, there's a linear alba? In the cheek. Let me hear you, brother. Where else in the body, apart from the anterior abdominal wall, there's a linear alba? That's why you would not know to take care before engaging with you. All right? Even in the exam, you will try to impress the examiner. Just be calm and cool, and just a second. Okay, some of you knew. And that lady in the red again. Red is the outside and the color. Yeah. Tell me where else in the body apart from the midline of the abdomen that you'll encounter a linear alpha. Huh?
It is.
The body around the back there. I didn't mention it, but I don't know if the lecturer did it to you or you read the books.
Is it in the?
Within the oral cavity, as a plane of occlusion between the upper and lower teeth, yeah?
Yeah.
Right at that, inside of that buccal mucosa, there is oftentimes, some of you can even feel a line, yeah? When they repeat years of trauma like this, or you can see this whitish line formed as a result of the repeated trauma, yeah? And that line is also referred to as the linear alba, yeah? Yeah, anyway. So the reason why I postulated the creation everything to come anteriorly is that when we're closing back the anterior abdominal wall, having made a long incision through the linear alba, it starts at the top and starts to close down, you know? You follow me?
We are not sure here. Give us a please.
I'm just wondering.
Coming over to the lightning fast.
Mr. Gardner is the lightning fast.
Help me, lightning fast.
That's how he drives, lightning fast. He's a man that will ride a motorbike, you know? So you can imagine man is motorbike. Our motorbike guys are fast. Anyway, so as we go down and close the linear, we have to catch everything.
There's still one
Focus anterior and posterior component. Are you okay? And as we go down, say we reach the lower part now, the infraumbilical region to the middle of the symphysis tubis as we are going down in that direction. We get to that area. That area is tight, yeah? So, to catch everything, both its anterior and posterior wall, down the street it becomes more difficult. Because remember you have one for distance boils from horizontal. Yeah? So the creator, even after surgeon will face this problem. So he said, I'm going to make everything now anterior placed. So when it's more anterior placed, all the knee sheet now, it's easier for us, the surgeon, to get them than if it was posterior placed. You can understand the logic of that? Okay, so the boss is ready now.
3 minutes, 3 more minutes, Patrick. I was thinking, please, it becomes dry off a little. What is the talk? 3 more minutes to talk.
So the skin, somebody was saying that the skin, yes, the skin has its own intrinsic lines. And the plastic surgeons make use of those lines. What are those skin lines called? Huh? What are these lines called in the skin? Natural occurring lines. Yeah, lines of London, never that occur. Yeah, they fall asleep. They're not drinking enough in the morning.
Who is falling asleep?
The people with the highest IQ in the world are which there is exactly. It's not a guess now, you know that about it's the Japanese. The Japanese are the highest IQ in the world. And which people in the world bring the highest amount of blue moon and coffee. That's where the blue moon
It's
coffee
Jamaicans.
By them. Are the Japanese there?
Which people bring the most blue moon and coffee.
Are the Asian then?
Japanese.
Closer, man, closer.
You know, you see Sir Steph is still beside him.
Start drinking your blue moon and coffee, man. Right? Start drinking your blue moon and coffee.
Patrick, ready.
Yeah, but you don't have to still wrap around this thing.
The what?
You see that there?
I'm so lost.
It's
What's going on?
So we see, first of all, many times in Patrick. Yes. So very sad this morning, you know. The guard died this morning. There was a young gentleman that is out right at the front there. At the gate to Friday. Very, very nice young man. All right.
So sad.
This morning, morning, some car was driving off his bike. And he hit the ground. By the time they were walking,
Your coffee is strong.
sad. Very sad, very, very sad. He said, so I remember when I was young, I used to like riding my bike. Coming right along by where Lucian is, that was a road coming along. And I was on my Honda, big Honda. And coming along, and then all I see in front of me is an oil slick right across the road. And the bike just went from under me, just flew from under me. And I went down to the ground, and my head just went, I still hear the sound of my head on the ground. But lucky I had on that day a full face helmet, you know, the top and everything on the way. Right, there's a good helmet, or a bear helmet. It's very powerful helmet, you know. And if I never had that on, dead story. Good video. Right. So this poor young woman this morning died. Okay, skin. Then you see umbilicus. And if we come right above here, we just look at that. We're just seeing a bit of this. Feel it with me. What is that? The ziphistern. Okay? So this is the sternum right here. Okay? So if we go a hand's breadth below this is the sternum, right? That's Lodenqai. Hand's breadth below the sternum, we should be coming right at the transviral plane. So this is the sternum right there. A hand's breadth below the sternum, and that's the trans. Pass some sticks low. No, it's out. Yeah, give it a chance. Yeah. Very good. Very good. So we're seeing something, but let's just talk first about this hand's breadth. So hand's breadth below, then this gives us the transpiral plane of L1. Very important. Now, let's just talk a little about this transpylor plane. Tell me what you know about it.
It has 13
Yeah, what do we know about that transpylor plane? Okay, remember now, you find it at the midpoint between the jugular notch and the upper border of the pubic symphysis. It's at the midpoint between the jugular notch and the upper border of the pubic symphysis. That's very technical definition. Or less is a bit less. Not bad though. Is a hand's breadth below the symphysis. Right? Now, where is this cutting? Who is right here? Anyone? In terms of the rib cage, tip of the ninth costal cartilage. Tip of the ninth costal cartilage. Okay? And at that point, this is where we're going to find the fundus of the gallbladder. The fundus of the gallbladder, and then, or we can go at a point called the mid-inguinal point. So that's there, or we can see who is this boy coming up right at the side here? Who is right here at the side? Who is this? What is this demarcating? This chart? This one here. What's that demarcating? And we can put it here. What is that demarcating? The linea semilunaris. Or Spiegel's line. Okay, that's the linea semilunaris. Okay? And we see a hand's breadth below this right there, that is the one. The transpyloric plane, and it's going to touch the what? The tip of the ninth costal cartilage. Right? What else is important about the transpyloric plane? What else is important about the transpyloric plane? A couple of things. Exactly everything goes. L1. What is important with L1? Right, Patrick? Nothing wrong with that? And that's where we're going to find the pylorus of the stomach. So the pylorus is right there. What distance from the midline? What distance? 1.5. At L1. 1.5 to the right. Okay? Who lies directly behind the pylorus? The neck of the gallbladder. Sorry, the neck of the pancreas.
My God.
Right? And who lies directly posterior to the neck of the pancreas? Brittany, who lies directly posterior to the neck of the pancreas?
Wasn't it the hepatic?
Formation of the hepatic portal vein.
Yeah, the one thing.
So the splenic vein is meeting the superior mesenteric posterior to the neck of the pancreas. Right? What else is occurring there? What else? Yeah, the L1. But more to the midline or a little more to the left. Who is right here? Right at L1. Celiac axis.
Oh yeah, that.
Right, the celiac axis. Okay, the celiac axis. Okay, the pylorus, pyloroduodenal junction, the neck of the pancreas, the hepatic portal vein. Right? And when we come over here, we're at what? The fundus of the gallbladder. And at L1 also we get the superior duodenal flexure. So the superior duodenal flexure is at L1, and the inferior duodenal flexure is at L3. Okay? So all of that is in relation to the transpyloric plane. If we come down a little below here, we're at which plane? The subcostal plane. And if we come here, there are three different planes that we're going to encounter. The highest aspect, to hold them like that, the highest aspect of the iliac crest is referred to as what plane? The supracrystal plane.
The super one.
The supracrystal plane, which is at L4. And then between the, and then that's the ASIS. Go relax, that's the ASIS. And right over here now, that's the iliac tubercle. And then That's at L5, that's the transtubercular plane. Transtubercular plane, that's where we find it at the level of the iliocecal junction. And then now this is referred to as the interspinous plane, S1. So L4, L5, S1. Okay? So very quick on that, many times. No, hold on. Okay, give us time. Relax, relax.
Where are we
Just
giving
relax.
it?
Very important is this. So we have to take some tape. And we have to take some tape and go from where to where? We have to go from ASIS down to the what?
The pubic tubercle.
Pubic symphysis.
Oh, my bad.
Right at the upper border of the pubic symphysis. Okay? Right, so that's ASIS, and then, one second. Where are the markers
There are
here?
two things happening at L4.
Oh.
Mainly.
Very good. So this is the ASIS, and that's the upper border of the pubic symphysis. Right, and right here, that is the mid-inguinal.
Period.
Right, mid-inguinal. No, show the camera there. Yeah. Zoom in on him. Good. That's the mid-inguinal point. Okay, so that is where the femoral artery is going with the external iliac artery.
Becomes
Right, Patrick? Becomes a femoral. That's the mid-inguinal point. Okay, then this boy here, over here, see him over here? Who is that man? Who is that man? See him right here too? Zoom in hard and in Britain, right there.
Pubic tubercle.
Pubic tubercle.
Oh, so the midpoint
And
of
this
the
big
pubic.
land up here, what's that land up here called? Pubic crest. Right, so that's pubic tubercle over here, way over here. This is pubic crest, pubic symphysis. And this sharp line along here is called what? Pectinal line. And then this big boy here is called what? This bone. It's called iliopubic eminence.
Yeah.
Yeah? That's the ASIS. And this is the anterior superior. Look how beautiful here. The anterior inferior. Anterior superior left hand. Anterior inferior. Iliopubic eminence. Pectinal line. Long area called pubic crest. And that long area called pubic crest. See, they're zooming in harder than Britain. More, just a little more. Right, pubic crest forms the base of the superficial inguinal ring. Right? This is the attachment of the lateral crura. That's the attachment of the medial crus. So lateral crus and medial crus. And this is the base. So a direct current is going to present itself right through here. Okay? And that's the pubic tubercle. And then inferior lateral to here. This is where we're going to get the femoral canal. So femoral canal is going to present, femoral hernia will present itself here. A direct width, a direct union here. Okay, but appreciate the difference between the pubic tubercle and the pubic symphysis. So therefore, they want to establish this fact, very important, put it in red, that this is the mid-inguinal point, midpoint of the inguinal ligament. There, see the bugger right here? He's lateral to the zoom hard. Right. So this boy is called mid-inguinal point. That's called mid-inguinal point. This boy is called midpoint inguinal ligament. Two very different things. Okay? This guy is lateral to this guy. That's fundamental. So this deep ring is about 1.5 centimeters above the midpoint of the inguinal ligament. And this mid-inguinal point is also called passing through there is Poupart's line. Right, because the inguinal ligament is called the what? Poupart's ligament. Right, so there. Now, very interesting that approximates very much so to what? To the midclavicular line, and approximates nicely to the linea semilunaris, lateral border of the rectus abdominis. Okay? So if you project this line upward, it will touch the tip of the ninth costal cartilage, the fundus of the gallbladder on the right side. So this is where the external iliac artery becomes the femoral artery. And just before it becomes the femoral artery, it gives rise to the inferior epigastric artery. Okay? All right, so we can put that on right here. So if we put this here now, the mid-inguinal point, mid-point of the mid-inguinal point, and that boy is at the mid-inguinal point. This one is now placed at this really should be here, but he wants to run over. This is now at the subcostal plane. Some books use the transpyloric or the subcostal. Okay? And then we use down here, everybody uses the transtubercular. Okay? And if we do that, then we define out the 9 regions. Okay? We bring this out a little more in. Then that's the left hypochondrium, epigastric, right hypochondrium, umbilical,
Left
left
lumbar.
iliac, right iliac, sorry, right lumbar, going too fast, left lumbar, umbilical, right iliac, hypogastric, left. Okay? Very good. Right. Now, you see, where's the process? Here.
Still
See,
very
first of all, that there is skin. And we see the skin is relatively thin. Nothing compared to the skin on the back. Okay, on the dorsal. When we reflect this, Brittany, who are we now encountering? I don't know. Who is this Brittany? Who is this person?
Yes, he was right.
I don't know. We are being called, you know. Who is this? So, this is a combination of campus fascia and scarpus fascia. Right? So this person had a very well-toned anterior abdominal wall. Very good. Very well. No what? Very little what? Very little what? Fat. You can actually count the adipocytes. Isn't it very likely they can actually count? Well-toned like a certain person in the body. Okay. So well-toned. So there we see all of these. We can see the adipocytes. But sometimes it's this thick. Look at this. So in a bucket over right over there, I have campus fascia that's about this thick. Right? Thick like that. Okay? So deep to that is scarpus fascia. So scarpus fascia deep. So this is all scarpus fascia. See there? That's all scarpus fascia. Now scarpus fascia is it's a membranous layer of the superficial fascia. Deep to scarpus fascia, coming back to it, Brittany, who are we getting here? Just this one step at a time. Who is this? External oblique. How do we know it's external oblique?
Because it's external.
The direction of the fascia. So as you see, all of that is what? External oblique. See, all of up here is external oblique. Okay? Which rib is it going to start at? Anybody tell me which rib is starting at? Rib 5.
5 to 12.
Reasonable? I'm going to sort of go at 8 from 5 to 12. So the upper 4 is interdigitating with what? Serratus anterior. And the lower four digitating with
Latissimus dorsi.
latissimus dorsi. So off of the lower four ribs, it's arising, interdigitating like that with the what? The latissimus dorsi. Okay. Then, what do we notice? Look at this right here. What is happening right here? What is all of this? What's all of this? What is all of that? Aponeurosis. So that's the aponeurosis of the external leaf. And it's going into the formation of this structure here. What is that structure? Rectus sheath. See the nerves and vessels emerging there from the rectus sheath? See them right here? Okay? Now, if we take a line from the ASIS to the umbilicus, ASIS to the umbilicus, what can we say about the external leaf? For a line taken from the ASIS to the umbilicus. It's all aponeurotic. It's
Oh, yeah.
all aponeurotic. Okay? It's all aponeurotic. So there you can see this person has a distinctive groove. And that distinctive groove you see is what? Is linear cellular nerves. Look how deep it is. Right? And then when it reaches up here, who is it hitting? Tip of the ninth costal cartilage. Okay? Now, below that line, sometimes people call it the spinal umbilical line of Monroe. All of this is aponeurotic. Okay? All of that is aponeurotic. Now, what can you tell me about the insertion of the external loop? What can you tell me about it? So there's a man named Anthony. Where is he? Right there, look at this. So there we look at that. Okay? And there's a man from Trinidad. Come zoom in on him. Ha. On the iliac crest.
Is it going?
So that iliac crest has an internal lip, an intermediate area, and an external lip. Everything is anterior 2/3. So the external oblique is attaching to the anterior 2/3 of the outer lip. Right? And then from the ASIS to the pubic cubicle, what is it doing? Forming the inguinal ligament. Right, so between these two parts, it's folded like that. See how it's folded like that? Into a what? Folded into a what? A gutter. A what? A gutter. See the gutter right there? Is that a good gutter, yes or no?
So we can't see.
Oh, you can't see it.
Yeah, it's beautiful, sir.
Right? So the external oblique comes down and then folds under itself to form the inguinal ligament.
Yeah.
If you said it's the free, inferior, inward border of the aponeurosis of the
External.
Then Dr. Lodenqai will tell you a little later that just a little behind it, posterior and a little inferior, and we'll show it to you, is the iliopubic tract. Right? So Thompson's ligament is right here, right along here, and then the inferior epigastric artery is coming up. And the inferior epigastric artery, hold it like this, pretty, just like that. Inferior epigastric artery, just having a little fun, and the lateral border of the rectus abdominis form the triangle of Hasselbalch. You can see the triangle of Hasselbalch there. So where we get our direct turn. So that's the inferior epigastric artery. That's the lateral border of the rectus abdominis. And there is the inguinal ligament. And the superficial inguinal ring is about over here, and that's where direct hernia will emerge. Okay? Now, little later on, we'll see that subinguinal area right below the inguinal ligament. We'll just hold it like this. That subinguinal ligament area is a very important area right behind here. Okay? And that's where we're going to get triangular what? Doom and triangular pain. Right? Triangle of doom is right here, and triangle of pain. You know,
Wait, actually, here.
right? So the inguinal ligament. So the aponeurosis of the external oblique comes down and between the ASIs and the pubic tubercle infolds to form the inguinal ligament. Right? And then part of it is reflected. We get a reflected part that goes into the linear album, and then that inguinal ligament that is continuing around, the fibers are going to continue around like that. So we're going to show you all these things, you know, as it comes around here. Okay, very good. As it makes, you see that corner right here? I'm pushing the forceps right up through it. You see where the forceps is coming up right through there? As it makes the corner like a car spinning around the corner, it's going to form something called a lacuna ligament or lacunar ligament. Then it's going to continue as the pectinal ligament. Okay? Relax. So the external oblique is very important. Okay? And goes into the formation of the inguinal ligament, and is going to contribute to the rectus sheath. No? There's a little lady here, Brittany. Brittany, this rectus sheath, when the external oblique becomes aponeurotic and it continues into the midline, what is it? What's along right here? Define the linear album. How do you define it?
It's the move from the.
How do you define the linear album? So a tendinous raphe. Extending from the
Visternum to the
this
pubic
is sternum to the
symphysis.
upper border of the pubic symphysis. So it's formed by interlacing fibers. Okay? Now, Brittany, when we come right here, look, we're just doing some fundamentals, you know. Just some little fundamentals we do. So when we reflect the external oblique, alright, when you look down here, okay, wow, see right here? I've reflected, and this is the lowermost part of the internal oblique. See it over here? So that's the external oblique, reflected. Look what's happening. It's going in the opposite direction. See the fibers? Going in that way.
That's the
So they're
interior.
going?
Yes.
That's the internal oblique. Okay, fibers are going superior medially. Right? However, some magic occurs down here. See the magic that is occurring right here? So the lowermost part of the origin of the internal oblique is off of the lateral 2/3 of the inguinal ligament.
Yeah.
So where's our thing right here? So this is very important to understand that from the lateral 2/3 of the inguinal ligament, boom, 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 all the way down here. See there, see the bubble? All of that is the origin of the internal oblique. See there? Lateral 2/3 of the inguinal ligament. And you will see that you have obscured the deep inguinal ring. So it's going to tell you that the deep inguinal ring has anterior to it the arching fibers of the internal oblique. Okay, Dr. Lodenqai will deal with that. Okay, that's his area. What? Give a hand. Okay. So there, very good. Excellent. So here, see right there? That's the, oh, that's it. See the internal oblique? That's the inguinal ligament. Right? And there we can see the internal oblique arising, coming over the spermatic cord, arching over, and coming back to form something called a conjoint tendon that is inserted into the pubic crest and the pectinal line. Okay? And there you can see the deep ring, and you see going in front, there is the internal oblique. Okay? Just relax. So The next thing is the internal oblique. So where is it arising? It arises from the lateral 2/3 of the inguinal ligament. Where else is it arising from? Back here. The intermediate area of the anterior 2/3 of the iliac crest. Where else? Thoracolumbar fascia. Where else?
Lower 6 ribs.
Which ribs?
Lower 6.
Some say lower 4, some say lower 6. Okay? Right? And then now what happens to the internal oblique? As it meets the linea semilunaris, it's going to split into 2 lamina. Right? However, that's the umbilicus, that's the upper border of the pubic symphysis, which will turn the specimen over and look at it. Back here, that's going to be a line called not a line, but an actual structure. The fold of Douglas, or the what? Fold of Douglas or what? The linea semicircularis, arcuate line or the fold line. So what happens basically is below the arcuate line, all the upper neuroses travel anteriorly. Now, what can you tell me about internal and external oblique? Go back to it, between the 12th rib and the costal margin. What can you tell me about the external oblique between the 12th rib and the costal and the iliac crest? Sorry. From the 12th rib to the iliac crest. What can you tell me about it? From there to there. Brittany, what you can tell me about? Answer. Free posterior border, forming a part of the lumbar triangular petite. Okay? Free posterior border. Okay? Now, deep to the internal oblique, there we see this boy. Who is this boy right here? Transversus abdominis. And if we zoom down on it, we see there's some nerves and vessels in there. So it's a neurovascular plane in the thoracic, in the abdominal wall, right? So you see the transversus abdominis, okay? And that's now arising from the lateral third of the inguinal ligament, okay? That's just coming from the lateral third of the inguinal ligament, just this third over here. See right there? Lateral third. This is coming from the lateral 2/3. Sorry, Brittany, right here. So that's the transversus abdominis, lateral third. This is the lateral 2/3. No, hold on a minute. Both these set of fibers, what happens to all these fibers here, Brittany, that are arising from the inguinal ligament? They arch over and form a common tendon called a conjoint tendon, which we will show you. The conjoint tendon. Okay, and that's going to insert into the pubic crest and the pectinal line. But the internal oblique now is, and a bit of the transversus abdominis is going to contribute to the roof of the inguinal canal. Okay? Alright, leave that alone. So the transversus abdominis arises from the lateral third, arises from the inner lip of the iliac crest, anterior 2/3, thoracolumbar fascia, and up here will take its origin from the inner aspect of the lower 6 ribs. Inner aspect of the lower 6 ribs. Okay? So when we turn the specimen over, now just to go back a little to the scarpus fascia. See that scarpus fascia? Very important. He gains attachment. He attaches along the iliac crest. And then the scarpus fascia, very important, and it has its relevance now to femoral hernias and all that. It's going to attach a finger's breadth below the inguinal ligament. It attaches a finger's breadth below the inguinal ligament and then continues into, so it attaches a finger's breadth below the inguinal ligament and then continues into the perineum as a fascia called Colles fascia. Right? So if you look right here, sorry, if you look right here, this is a female, and scarpus fascia is going to go into the perineum as Colles fascia, and it's going to gain attachment to the everted edges of the ischiopubic and the posterior border of the urogenital diaphragm. Okay? So we should know about it. Now if we turn over the specimen, so we turn them over, good. We are looking at what? Or what are we looking at here? Peritoneum. See, that's peritoneum. Okay? And this structure that has torn, that's the falciform ligament. See the falciform ligament? And we see here the ligamental teres hepatis. So this is all peritoneum. See how it's smooth? That's peritoneum. And what lies superficial to this peritoneum? What lies, see the diaphragm here? See the diaphragm? So the transversus abdominis is going to interdigitate with the fibers of the diaphragm. Because the diaphragm is coming from the inner aspect of the lower 6 ribs. No. Give a chance. You see here that, just relax. We see these folds right here. Brittany, come and zoom down on these folds here. So, what I can do is give a chance. I can do some improvising. We want to lift this up, you see? We want to lift it up. Move that way. There. Just hold this back like that. There. Excellent. So in anatomy, you have to be buffing. Who are these folds right here? Who are these folds here? How many folds have been built? 5. There will be a medial one, which I'll show you better in another specimen. 2 medial boys, and out here 2 lateral boys. The lateral boys are formed by the inferior epigastric vessel. See the inferior epigastric vessel right here? So it raises a fold. That's the, sorry, not inferior, the inferior epigastric vessels. That's the lateral umbilical fold. Then this boy here is the medial, and that's formed by the obliterated umbilical artery. Then one I'm going to show you in the midline is the median, that's formed by the obliterated urachus. Okay? So there the inferior epigastric artery right there. Okay, let's put this one down. Okay, give a chance. Okay. Let's get another specimen. This guy here ready. Hold this way. Just hold it. Excellent. Pretty up to that one. Okay. That specimen back there has more alcohol. I may be encountering some formalin here. Alcohol is wrong. So, in this boy, let's look at this boy here. So, Brittany, there. I mean, sorry, Brittany, which is full. Right over. We're looking here at the umbilicus, and we're looking at the falciform ligament, and we're looking at and seeing some veins, distended veins. These are called the para or adombilical veins, or the venous plexus of Safi. They drain up to the left branch of the hepatic portal vein. These will drain up to the left branch of the hepatic portal vein, and beautiful, see right here, a median boy. See the median boy there? That median boy there is the median umbilical fold, contains the medial umbilical ligament, which is the obliterated urachus. And the medials are from the obliterated umbilical arteries, and then over here, look how beautiful that is. So in the exam, there's a whole station or two on anterior abdominal wall, and there's the inferior epigastric artery. Look at that. That's inferior epigastric artery right here. That's the lateral border of the rectus abdominis. So that boy there is Hasselbalch's triangle. See Hasselbalch's triangle right there? Right there. Okay? Now, what has happened is that this posterior rectus sheath is covered by peritoneum. If I stripped off the peritoneum, which I will not, you will see that about midway between the umbilicus right here and the upper border of the pubic symphysis, you see something that is arching like that. And that is the one. That's the fold of Douglas. So that's the posterior part of the rectus sheath. Pretty versatile. Just 3. Okay, because I will leave that over to my colleague Peeler then. Very good. So, very important that the blood supply above is coming from where? The superior epigastric artery. Okay, that superior epigastric artery is coming from above, from passing through a little opening in the diaphragm. Okay, Dr. Wonderful is going to talk about that opening. So there's some new things about that opening. Right? Some new stuff coming out of the opening where the superior epigastric artery is asking to address it. It's going to enter the rectus sheath, and then the nasal goes with the inferior epigastric artery coming out. Now, if you look at the rectus abdominis and its anterior aspect, here's another specimen. But if we look at the rectus abdominis on its anterior aspect, right, everybody, you see that there are these things called what? Tendinous intersections. Where exactly do they occur? Where are they? Where are the location of the tendinous intersections? 1 at the ciphisternum. 2 at the umbilicus. 3 midway between the ciphisternum and the umbilicus. And a variable one below. Right. So the 2 vessels. Then we have the lower 6 intercostal arteries and nerves leaving their spaces and entering the neurovascular vein of the anterior abdominal wall. There are a lot of other arteries Dr. Lodenqai will talk about. Okay? Just to say that in that campus fashion, in the subcutaneous layer, we encounter a vessel called the superficial epigastrics. What's the name of the vessel? The superficial. There's a superficial epigastric artery, and there's a vein. The artery is coming from the femoral artery, and the vein is draining into the what?
Great saphenous.
Into the long saphenous, or great saphenous. And there is a portosystemic anastomosis at the umbilicus. So it will anastomose with the para or adombilical veins, which are going to drain up to the left branch of the hepatic portal. Relax. We find also that there is another vein that's going to connect up into the axillary vein. So above the umbilicus, we'll find out that there's a vein that's going up that may become open and be radiated to be a major highway of traffic when the IVC is blocked or compressed. When it's compressed. And what is the name of that vein going up superficially? What's the name of that vein? The thoracoepigastric vein. That will drain either into the lateral thoracic vein or may drain directly into the axillary vein. Okay? So when there's a compression of the IVC, blood will go from the femoral vein using into the great saphenous, superficial epigastric vein, thoracoepigastric vein, up to the what? To the axillary. Okay. Lymphatic drainage below the umbilicus. What can we say about it? Joel, what do we know about the lymphatic drainage below the umbilicus? In the exam, all over in the exam.
Oh, alright, you should make it really good.
So this answer is the answer to many questions. Medial group of superficial inguinal nerves. Medial group of superficial inguinal nerves. Many questions have the answer. Medial group of superficial inguinal nerves, including the anal canal below the pectinate line. Above, where is the lymphatic drainage to? Above, where is the lymphatic drainage to? To where the breast, 85% of the breast is going. To the axillary nose. Isn't that so? To the pectoral root of axillary nose. That's level 1, right? Level 1. Sorry. Very good. Okay. Take this away, Pretty. Give it down. I want to get where you go. With what kind of fluid? Cadaver fluid. Away with it. So I'm just going to sit back just 2 minutes and 2 minutes, alright?
Maybe it's done one of those trains.
So I'm going to show you a little of the nerves that we're talking about. Okay? So there. So usually we can call the word hard. Hard. Yeah. Really. Let us see this one. Very good. Okay. Oh, this focus. See the nerve I'm looking for? This one. This one. See him? This guy. Alright. So this is in the exam all the time. Okay? If you can hold this a little enough for me. Yeah, perfect. Just for 5. Just listen. Just for 3 minutes. So we see 12th rib. 12th rib. Immediately below the 12th rib are the subcostal nerves and vessels. And that subcostal nerve is going to end in which muscle? Brittany, which muscle does the subcostal nerve end in, though? It's pyramidal. What's the name of the muscle? Pyramidal. He lies in the rectus sheath and he tenses the linear arm. Okay? So remember the lower 6 intercostal nerves are going to get into the rectus sheath, right? The lower 6. Thoracic nerves, they leave the plane and then there comes thoracic nerves and go through and they enter the rectus sheath. Okay? So there you see the subcostal nerve. Then who is the next big boy? Virginia, who is the big boy that comes out? So that is the psoas major. You're looking at the sagittal pelvis. Right? That's the so you look at the posterior down. Come down for a little, Virginia. Down for below. Further. You just wanted to get an idea where they come up right off. Very easy. See where you're looking at the posterior abdominal wall. Come back in again. Yeah, tell it. Till there. Right. So then, there you look up at the big boy. Subcostal is T12. Then iliohypogastric, T12 and L1. The iliohypogastric nerve has his L1, and that iliohypogastric nerve ends up he's piercing the external oblique aponeurosis and supplying where? Supplies the skin of the mons pubis, the so-called bikini area. Elisa, what is her name again here in front of me? Crystal. Yes, Crystal. So it's going that is going to pierce the aponeurosis of the external oblique. Then, so we see now subcostal, iliohypogastric. Next boy is ilioinguinal, L1. Then we find going to out here the lateral cutaneous nerve of the thigh. And then we're going to see now the femoral nerve. Okay? Now the last thing I want to show you that's always in the exam, coming out through the psoas, that's the genitofemoral nerve, L1, L2. Genitofemoral nerve, L1, L2. Okay? And this coming here is the femoral branch. So that's the femoral branch. So this little area is called triangle of pain. Right? So they never want to tack anything along here, because there you find the femoral branch and the genitofemoral, the femoral nerve, and the lateral cutaneous nerve of the thigh. This is going way out lateral. Okay? Now, last thing to show you. Last thing, right back here. Lodenqai, last thing to show them. But then you have to come down very hard on this. Excellent. So that's the femoral ring. This is the inguinal ligament. See the inguinal ligament here? And we're taking this corner and coming around. That's the lacuna ligament. That presents a sharp presenting cord. And then this boy, there, that's the conjoint tendon. See the conjoint tendon there? Going into the pubic crest and extending into the pecten pubis. Alright, so there you can see, and living in that's the entrance to the femoral canal, and living in here is a lymph node, and that's the node of Lodenqai.
Yeah.
End of story.
I want to stay there.
You want to use this one?
Just for the minute.
Okay. You have to change drivers. Change drivers.
Yeah.
Every time you do this, like you do this bad That's how it feels on some.
Okay.
Let me check the battery percentage.
No.
Some of the way you just from the snow. I don't think I really
You can't.
Yeah?
I don't think I really look at talking to them.
What happened?
Because
Reflexes.
my views about this area is a little bit more different to what the surgeons would take down in your exam. Will be checking it. And since they are going to be in the exam with you more than
No, we're all there in the next.
no, these guys.
Okay.
If you go through something and then it may be a problem. You see what I'm saying?
No, man, it'll be all right.
I'm not too sure.
You will be all right.
Since Mr. Gardner last specimen just highlighted the femoral canal or ring, and this specimen will be highlighted as intelligent connotation here. Yeah.
Pretty considerable. Pretty better.
You remember this, Mr. Gardner had showed to you. Yes? And this will be the inguinal ligament, yeah?
Yeah.
And the medial attachment of the inguinal ligament results in a sort of a V-shape attachment, yeah? Mr. Gardner highlighted them to you. That we had he called it a lateral and a medial, that's what you call it, eh?
Correct.
Some people call it superior and some people call it inferior. So how many crura do you have here at superficial ring?
3.
He mentioned 3. You want to tell us the 3 that we were teaching this girl over here? That's what I'm asking.
The posterior and
Right, the previous 2 which I said, Mr. Gardner, I highlighted to you. And there's a so-called reflected cross, right? The French call that the 3rd cross. Yeah? And it's on this 3rd cross that the spermatic, I'm going to use the male, spermatic cord structures will line. Okay? And at the superficial ring, we won't have a specimen because it has been dissected. We have some fibers that maintain the integrity of the superficial ring. Do you remember what those are called? They are running between the superior and inferior cord, or medial lateral cord. Just like that. What you're going to name them? Here, you're going to name them.
Patrick.
No. They are running between the superior and inferior cord. Fibers are running there. They are there in. Huh?
I don't know.
You're going to give it an English name. No, we don't say this thing. Yes, this is trying to show the greenish fibers which are running here, but in real life they can be more pronounced. Yeah? Going all the way up, following fingers there. You see the greenish fibers there? Running somewhat deeply between the superior and inferior fluid, the fingers are continuing. And you all know what that was our noted? My friend here with the white shirt is looking asleep, touching behind there. What his name is? No, he's not. That gentleman there, man. Yes. See, holding yeah. He's having a good slumber. What do you call these fibers? Pardon? You have to tell them, brother. You see, they fall asleep on us. And you told them, man, I need you on the thing here. Something fibers running between superior and inferior or medial. They're running between, so what are you going to call them? The intercrural fibers, man.
Wow.
These just maintain the integrity of the superficial ring. They do not prevent an inguinal hernia from forming. You understand me? It's already formed, it's in the canal, but they might impede the egress of the hernia coming down. Yeah? Just maintain the integrity. You follow that?
What are the fibers called?
Inter between crural fibers. They just maintain the integrity, but they don't prevent the formation of inguinal hernia.
So what you're saying is that they prevent the hernia from protruding?
Yes.
Sir, are they also referred to as posterior fibers?
Sorry?
Are they also referred to as posterior fibers?
No, intercrural. This is not the 3rd crossover in the reflex.
Oh, okay.
That's totally different. Now, at the deep ring, is there anything happening at the deep ring that we should know about?
Not much, sir.
Not much.
The inguinal nerve
That
exit.
young lady, she's a dental student, no? The dentist always look more
I think that's what
distinct
it's-
medically than the rest of the medical students. You know? But you have to take the exam to know this. Yes, they have to take the exam.
Do everything, Patrick.
So you can
You guys do
down
anything at
to
the deep ring?
And
No.
remember, they're going to have to deal with that. and everything, you know.
I also see the nerve exits from there.
Do you know about the interfoveal ligament or? Huh? A fovea is a ligament. No, at the deep ring. Yes? Here's a ligament called the interfoveal ligament of Hasselback. The same man of the triangular Hasselback. Yeah? And Mr. Gardner had showed you or mentioned to you the iliopubic tract of Thompson. coming from the ASIS, or posterior and inferior to the inguinal ligament. Yeah? This ligament, interfoveal ligament, runs along the posterior inferior aspect of this deep ring, which Mr. Gardner showed in his diagram. Right? And these fibers, the pubic tract fibers, which are coming from or related to which muscle again?
Transverse.
To transverse abdominis. Those are other fibers, they form a V-shaped structure, so that when they contract, when the transverse abdominis contract, you see, they narrow down the deep ring. Yeah? You got me now? You understand that? And this now has a real role. Yes? The interfoveal ligament, the lower part is formed by the iliopubic tract on its way down here. And the fibers of the transverse abdominis, upper neurosis, yeah? They happen right here, they form a V-shaped structure at the leaping with the ring. So that when the transverse abdominis wants to contract, you see now where they want to close off the deep ring. And that no, so you see now this actually takes a part in prevention of a inguinal hernia and indirect hernia from coming through the deep ring. Eh? That makes sense to you guys? Good. So that's a good mechanism. Now, a third mechanism, a second, well, I've been going to different mechanisms, but you all heard about the inguinal shutter mechanism?
Yeah.
Yes. That gentleman is the gentleman I can't sit up with you guys. Yeah, with the book open. Now that you've read it, what is the inguinal shutter mechanism? Inguinal shutter mechanism. When we're going to be having storms coming all these stores, you know, they pull down the shutters, don't they? So that nothing can, the windows can be broken or people breaking. What about the inguinal shutter mechanism? You know anything about it? Read it up there, love? Yes.
Oh, let me tell you, it's right here.
It's right here. All right, shut the book up and tell me.
No, I'm not reading the book. I'm reading it from the book.
Don't read it from the book.
No, I have to read it. I'm going to read it first and then I'll tell you after. So it says, the arching fibers of the muscles that make this tendon contract, when the abdominal muscles contract, this will act as a shutter mechanism on the posterior wall of the inguinal canal to prevent it from a hernia from forming.
Okay, so express to me now what's going on.
That's it, yeah.
Express to me now.
Yeah, that's it.
Express to me now.
That's it, yeah.
No, that's what I read. Say it loud now to me. No, that's how I want you to express it better. It's not you're writing fast, trying to keep up with your brain.
Okay, let me see. Let me read it one more time.
No, we won't give it one time, it's time not for us. So, we know that the internal oblique muscle, Mr. Gardner says that coming laterally from the inguinal ligament, and some fibers as well of the internal oblique, yeah? Laterally. So if my fingers are the origin of the transverse, my fingers are, these fingers are rising from the inguinal ligament here. This is the deep ring with the cord structure from here. So my fingers now coming from the inguinal ligament here. And they're going to be arching over. Some books use the conjoint tendon. Some people say we shouldn't use the word conjoint because they don't join up. We should use the arch, the transverse, the arch of the transverse and the internal.
That's too long.
The conjoint. Let it read whichever you want to believe.
That's too long.
Now you can see where the arch over and around the deep ring, with the cord structure like a thumb. It's coming over now, And Mr. Gardner, the books will tell you that they form the upper inguinal canal, yeah? And if you follow these fibers of my thumb, they are not going where? Where are they going? They are going medially, yeah? So, inside the finger.
The pubic
Along this line here. Yeah?
So is it the pubic line or is it the pubic crystal?
Sorry? Pardon? Within.
You're saying it's gonna come like this,
And arch over here.
and it's gonna go here.
Toward the pubic tubercle, yeah. Okay? So, when they transverse and the internal oblique contract, you see where they tend to pull down, yeah? And they want to close off the posterior wall of inguinal canal, like a shutter, yeah? You know when the guys pull the Chinaman and pull out the shutters off the shop?
Yep.
Just shutter it off. So that's the inguinal shutter mechanism. Yeah, anyway, these fibers protect the canal
To prevent herniation.
immediately, reinforce the anterior wall, so nothing will come through that region, right? And it locks off the canal as well, the inguinal shutter. Yeah. Now, Mr. Gardner highlighted to you the iliopubic tract of two again. The iliopubic tract of Thompson, yeah? Extending all the way from the east side is towards the pubic tube, yes? But the inguinal ligament is anterior superior placed, yeah?
Yeah.
And there's some attachment to the lower part of the inguinal canal here to the pubic tubercle, yeah?
Yeah.
And from the pubic tubercle, a portion is going to be reflected. It's not reflected, it doesn't show any reflection here. But it's going to be reflected along this line here. Yeah? And that's the pectineal line. Right? And this ligament that is reflected is called the pectineal ligament of
Douglas? No,
Off.
it's not.
The lacunar ligament.
It's not Douglas.
Cooper. You know Mr. Cooper?
Say it louder and
Ashley Cooper in English. Ashley Cooper.
And say where
An Englishman. So you understand the reflected portion? So you understand that generation was taught to us all the way. And it's in the books today. But
Makes
they have
sense.
now discovered the real truth, further truth. Mr. Gardner highlighted to you the iliopubic tract of Thompson. It's posterior and inferior and runs parallel to the inguinal ligament. So when it comes to the pubic tubercle, yes, it ends there. Or some ends there and is then reflected.
Excuse me, sir. Could you go back over that, please? You said it's posterior, superior, and also it's
No
parallel.
man, you said no, I don't think that ends.
Superior, inferior.
Inferior, it's posterior and inferior to the inguinal ligament. Yeah? So you see the inguinal ligament goes up here, but it's running posterior behind
Okay.
and inferior to the building. So when you use the pubic tubercle, it through something reflected onto Cooper's ligament. Yeah? So all your books tell you that the medial boundary now of the inguinal canal, in real life it is like a V rather than a circle. Your books have it as a circle, don't you? And all the pictures that you see circle. It's
Yeah.
really like a V, with the tubercle being the apex of the V. You with me?
Yes.
Makes sense.
So the pubic tubercle is the medial portion of the femoral ring.
Right.
And the superior or upper board of the ring is not the inguinal ligament, but what? The superior upper board is V-shaped, you know, like that. Superior border of this
What did you
this femoral ring
Yeah.
would be what? Not the inguinal ligament, which you will tell you. it will be the iliopubic tract.
Trust.
You understand me?
So you need to put on
This
it.
is where we something different with more. Yes, this is more modern.
You're getting into more
modern
finer
concept.
detail or more finer detail.
So
And
the
we-
iliopubic tract.
Oversimplification.
Yes, the lacuna ligament is
Yeah.
a simplification of it. But that's why I'm not good for you here, because I'm confusing it. Not really confusing, I'm telling you the truth of the matter. But not all of the guys, most of them don't know about these things, you know. Because some of them were taught by me, and that was years ago. And the inferior part of this canal ring is formed by the pectineal ligament, Cooper's ligament. Yeah? And the base of this triangle is formed by the, remember the femoral sheath, the canal ring, that means ring, you know?
Yeah.
And it's divided into compartments, no?
The lateral
So that be the
medial,
It's divided into how many compartments?
3.
3. So what can divide a single into 3? Two. There are 2 fibrous septa, don't it?
Yeah.
So it's the medial septa. And just lateral to it is going to be the femoral vein, which you will tell you constantly the femoral vein. Eh? So this is what I wanted to highlight to you guys, you know? Now,
You can.
Can't tell if I sleep now.
Brigitte, you can zoom in hard there. One second.
All this time there's certain serious
No, what is this?
right here,
Yeah, good.
right here,
That's perfect. That's perfect.
you see thing is more V-shaped than a circular canal, you know?
Yeah.
Yeah?
Yeah.
Right here.
It does look V-shaped.
Doesn't look V-shaped. And this part here now,
But wait till it's a bit.
this is the femoral ring. And this aspect now is the anterior superior wall. And that's Thompson's ligament then. It's way toward the cubic tuber. Yes. And the posterior wall will be formed by Cooper's ligament here. And the femoral vein should be more. Okay, so you understand the femoral canal, yeah? And Mr. Gardner had shown you, we have a lymph node there now. And we know the name of the lymph node, it is.
Focus, no. Focus, no. Another?
So you bring inter, yeah.
Anatomy is a language, you know, a new language, and you have to learn a new language. And the only way you can learn a new language is by speaking it with each other, not to yourself. You speak it, if you speak it to yourself, you're gonna get crazy, you know?
Well, I do that all the time, so probably I'm crazy.
Right, and you said it's the gland.
So it's the medial group of the
No.
No,
Yes,
it's a
I-
different node.
You heard something which is true, but it's not related to the question I'm asking.
Yes, for the nose.
I'm asking if I just know that I picked up right here, right within the femoral canal. Understand me?
I don't
And
know.
then a specific deep inguinal node. What you mentioned about. What you said it was again?
Yeah, inguinal.
Superficial inguinal nodes, infraumbilical,
So
the
this one,
lymphatic drainage. Those ultimately will drain into deeper nodes, and the glandular Lodenqai is within the canal, and it acts as the final between this lower limb coming up into the pelvis.
can you repeat that please when you turn your head from the mic?
The glandular Lodenqai, that terminal node within this femoral ring, is the final node before leaving the lower limb to the lymphatic system into the pelvis. Nodes the vesical clavellum external. Understand that? Okay? Understand that?
Yeah.
No.
So, sir, what's the ball? What's the ball mechanism?
The premasteric plug.
Yeah, the cremaster flow.
So, the ball and
Yeah, when you contract the cremaster muscles, the cremaster muscles.
Remember say and just touch the canal, okay?
Remember what the cremaster muscles are about?
Yes.
I'll just repeat that to you.
What is it about?
Take it away.
They grasp the scrotum. The scrotum.
Okay.
Yeah.
In the male, within the canal, there's a structure called the spermatic cordon.
Yeah.
And you know, Mr. Gardner, did you mention the word three to them?
3 1.
Three, no. There are number three structures.
three arteries, three muscles.
So there are three fascia. And you've been exposed to the three fascia. The outermost is called the, you guys,
External spermatic.
the outermost is called the external spermatic fascia. Yeah? When the cord structures pass through the superficial ring on its way to the scrotum, yes, it drags a fascia, yes, with it,
Yeah.
which forms the outermost covering.
Yeah.
So the external spermatic fascia is not within the inguinal canal.
Yeah. Not
It's
really.
beyond having the cord structure must pass through the superficial ring, not it,
Yeah.
to acquire. And where the external spermatic fascia is coming from. Me and Mr. Gardner might have little differences or the books. The old time book says coming from the,
External.
they're coming from the Kura. Yes, sir? The books, what did you read? You remember we showed you the Kura here? At the superficial ring. Yeah? Or some people might say come from the aponeurosis of the external.
Yeah, that's what I was
Big
saying.
aponeurosis, huh?
Yeah, that's the one.
But the current concept, they believe is that we talk about the superficial fascia, campus, which is the fatty, scarpus, the membranous layer. So where's the deep fascia of the anterior abdominal wall? It must be in front of the external oblique node.
Yeah.
Logical, you know.
Yeah.
And in fact, there's a fascia. When we do the last, the second surgery, we see there's a fascia. Yeah. And some people call the fascia of the external oblique, or Gallaudet fascia. And it comes down over the superficial ring. Gallaudet, G-A-L-L-A-U-D-E-T. Gallaudet fascia. It comes down just like that, in front of the superficial ring, and goes on to the thing. Huh? Good. So you know about the external. So anatomists, we guys are logical. That's why we don't study much. If we have an external, we must have an
Internal.
We call it thing.
That's the
So what is internal spermatic fascia about? Right. As it passes through the deep ring, it drags the fascia with it there, you know? Gets a covering there. Yeah? And the fascia there is the call of the fascia transversalis. Some of you ladies, when you get the babies and the baby acquire a certain girth, and you know the time takes a set, but that is always there. So that big belly stays in them. And when they have to go to these balls and things like, and you can well, they wear a thing to hold in the belly. That's what they call the thing that they wear in brother.
Corset. Corset.
Yes, man, they wear a girdle, you know. And some people refer to the fascia transversalis as the abdominal girdle. You follow me?
Yes.
So you understand the external spermatic fascia and the internal spermatic fascia. Now the Americans, their English is different from us. In a sense. Yeah, got it? Than the English language. Anyway, the Americans say we have an external and you have an internal.
And then
Then the one in the middle should be called
cremaster.
should be called middle spermatic fascia.
I'm a
Don't they? And in fact, they do call the middle spermatic fascia, the middle spermatic fascia. But we the English people don't call it so, because they don't give that name to us. You understand? That name was given to us. Well, you enjoy your kind of thing.
I asked a question about that. He asked if women have this as well. The fascia.
Yes, man, they all have it. It's the cremastric fascia that we were talking about. Yeah, Mr. Gardner lifted it up and showed you when they contract in school. They pull back all of these structures that are coming through the deep and help to plug the hole. Yeah? It's not always dramatic, but we have this thing back. Okay, so you understand that?
I do.
Yes.
Okay, so to get into the inguinal canal,
Maybe.
yeah, we come on the field for the pubic tubercle.
Yeah.
Pubic.
We might feed for the femoral artery. But the femoral artery is that where you'll find the deep inguinal ring, a centimeter above. Inguinal ligament. Yes, go on, so
So
diagram.
1.25
Yeah, show them on
centimeters
the
from
diagram.
the inguinal ligament.
1.25 to 1.5 superior.
Something.
The deep ring. You have to find the deep ring in surgery. Everybody gonna get an inguinal organ when you reach your finals. You have to know this here inside out. So we have to feel the pubic tubercle, and just above the tubercle is where
Oh, you know what is a
the V of the superficial ring is gonna be, right? And Mr. Gardner showed you where the deep ring. I'm saying you can feel for the femoral artery. Yeah, that's where. And that's the meaning with that one. And where is the deep ring in relation to that?
In relation to the, but it's at the, it's 1.5 centimeters
Above the inguinal ligament.
They know that.
Okay, so make sure you know that, because you have to find that. And surgically we find that, and we make an incision. Some people make a transverse incision, some people make an oblique incision along that line of the canal. It is about 1 centimeter above the inguinal ligament. It's about 4 centimeters long, right? Inguinal ligament? Inguinal canal, sorry. They can go on they can only talk about you so in the ones now, what's the relation to the superficial and the deep? We can't forget the pediatric population. In fact, we're going to be building a pediatric hospital in floor down in Montego Bay, so they're going to need a lot of pediatric surgeons to work over here.
Thank
A
you.
lot of you girls will love the pediatric surgery.
No, thank you.
So in relation to the little children now, newborn one, where the superficial disease
Just children, yeah, deal with that. I
so
remember.
they receive 4 centimeters as you and there's a sturdy.
So you for reading anatomy. Trees.
Because children anatomy is so much different
Born
than
infants
adult
and children. They cannot be 4 centimeters, that's all, you know? That is reality.
Green spell.
In fact, in the little ones, the superficial and deep rings are almost over approximately each other. And you have to be aware of it, you understand?
So wait, sir, as you age, like
So
the
in the
canal
baby like that, say
widens.
like that, and then now at the anterior block.
As your pelvis, especially your girls' pelvis, get bigger, then you can separate it more.
Crystal, it's like,
It doesn't come apart.
so the baby is in the middle. But in general, so the obliquity confers of valvular, becomes valvular because of this obliquity.
So is it adults are more likely to have hernias than children?
See, I know that. You understand that so far? So we're going to cut through the skin. The next thing that we are finding is the fat, campus fascia. And the next thing that we have to encounter is scar of the membranous touch through that. Yeah? And now we are on top of the external limbic capillary. Yeah? You look for the superficial ring. It's easy to find the pubic tuber. Yeah, feel with your fingers. And the areas is intercrural fibers. And we just clip superior anteriorly, yeah? And lift it a little bit anteriorly, and it will identify the canal. So look a little bit into the canal, yeah? And having done that now, in the canal, so this canal has been totally...
Patrick, we could use the big body now, you know.
All right, you want to get it from the back?
Yeah, okay, guys. It's fast, lightning.
We'll get into the canal. Yes, come on,
Lightning.
Hello? When I'm in.
all right, then we get
Half an
what you order. Something like that. Let's see that this is profit. Okay. So we have the inguinal ligament here. Yeah?
Oh,
The story.
Oh my God.
Pull this out. Sorry, Patrick, please. Pull this out, quick. Pull it out, man. The table.
Sorry, put it in here.
No, man, no. Or Britain is there.
what's going on?
That's it. Every time I'm here, just 14 minutes long. So like,
Dominic's man's gonna move it.
Okay, well, I didn't want it. Surgeons always operate this side, the side that they're working. Okay. I'm working on the right side here. And it's over there too. And I'm on the left side, so I'm wrong. So you follow me? I need to see that does it. Okay. So we can feel the pubic tuber right off here, yeah? Right on this morning prominence.
Good job, Brandon. That's why we need Brandon.
Right, yeah? This is inguinal. So we need to talk about three arteries then.
Yeah.
What are the three arteries? You can sit up if What are the three arteries? What are the three arteries? Right, one is the testicular artery.
The artery to
The cremasteric artery is another. Yes, and the artery to the vas. Okay? So those are the three named arteries. Yeah? They have veins now. The veins will fall similarly, those, right? Okay. Good. What about nerves now? You can tell the three nerves are more here. Which one?
Genital branch of
The genital branch of the genital femoral. Remember, Mr. Gardner showed you the genital femoral nerve. it comes through the deep ring and relates it through the superficial. That's one. What other nerve?
Inguinal.
Inguinal. Now, where would you normally find that?
I mean,
In the inguinal canal.
anterior to like the bus. No, never mind.
Sometimes you find it, sometimes those guys will zap it. It's usually said to be anterior
Oh, I was
to
right.
the cord.
Okay, I was
That
right.
is the structure here. This is probably this structure here. Yeah. The iliac nerve extends to that other thing. It's always anterior to the cord. Yeah?
Yeah.
The iliac nerve. Yeah. So that's one nerve. Huh?
Yeah.
Any other nerve?
Well, you have the sympathetic part.
The nerve, the cremasteric nerve, the cremasteric muscles get nerve supply, and the cremasteric nerves are coming from what?
Well, the
The
cremasteric
cremasteric
fascia.
muscles are what type of muscles? Smooth muscles or straight muscles? Straight. Yeah,
I always said it
straight.
when I opened the door.
Yeah. So where are these nerves to it? The cremasteric. You all mentioned this nerve already to me.
Oh, the.
But the
Genital branch. Genital.
Oh.
Yeah. So much nerve we're going so far?
Two.
Three.
Three. I think
Three.
we said the genital branch of the genital femoral.
That's
We
what
also said
Yeah.
iliac inguinal, and then we say the cremasteric.
So come you was
But the cremasteric is coming from the genital femoral. So it's tied up here, so that's still two.
Iliohypogastric.
Sorry?
Iliohypogastric.
Right. The parent of the iliac inguinal nerve is that is which nerve? Okay. The iliohypogastric nerve gives off the inguinal nerve in the posterior. Abdominal. Yeah. It is the collateral, when they did the chest wall, they talk about the collateral branches of the thoracic nerve. It is the collateral branch. Eh? You follow? So that's there. It's not within the, it doesn't come through the deep, so it's not within the cremasteric cord. Eh? You follow? But it enters into the inguinal canal sometimes. Eh? And it's always found in relation to the internal oblique muscle, anteriorly. But sometimes you see, sometimes you don't see. All right? And there's a fourth nerve which you guys might not be aware of so far. My colleague mentioned it. Huh? No.
Oh, somebody.
Yes, with the blood supply running in with the arteries, you'll have the sympathetic nerves coming
Wow.
down. Understand me?
Anti-Vincent.
And there's one other developmental structure. What is this within the cord structures?
Or the bracelets.
Huh?
Processes.
Right. All of us in the initial stage of development will have a processus vaginalis in the so-called indeterminate stage of the fetus. Right? Yes, the body then was identified as male or female. So they created me that way, and everything was being prepared that it could be male or female. So the processus vaginalis always precedes the descent of the testicle into the scrotum. Follow me? So processus remnants is always there. Yeah? But in some little infants, now when they're born, the processus does not fibrous and obliterate off. Sometimes it may persist. Yeah? And when it persists, it will give rise to an inguinal hernia.
Yeah.
And my girlfriend is the black deer. Where would this, in the infants know, where would this indirect hernia come through? In relation to the inguinal. Huh? What forms the posterior wall? If I ask you that, you're going to answer. What forms the posterior wall of the inguinal canal?
Yeah.
You're slim and nice now, but one day after pregnancies and some multiple pregnancies, you may get like a belly, and you can't get off the belly, and you have to look slim and nice to go to the graduation reunions, they call them, not so. So you might have to wear a what to keep in the belly. Yes. And we said, what was your abdominal, natural abdominal girdle? The fascia transversalis. So the posterior abdominal wall is formed by the fascia transversalis. You understand me? So all hernia must come through the posterior wall, yeah? The indirect ones come through a natural opening, which is already there, the deep inguinal ring. Yeah? So in the little babies now, yes, when this process does fuse off, where does this inguinal hernia come through into the inguinal canal? You know that. Same lady. You with me, sweetheart? You with me?
Is you
Yeah, man, the same lady in the black, you know. In the little infant, the same question. When they get the indirect hernia, because the process does not fuse off, it remains patent, you know? And when them cough, you see the bulge. That hernia comes through what part of the inguinal canal? Through the posterior wall. What part of the posterior wall? What you said? Which part of the transversalis fascia? Through the deep ring. An indirect hernia. You have to understand this, you know. Remember, all of you going to get an inguinal hernia in the clinical exam. An indirect. No, but you have to understand it from now. An indirect, you pay attention. You're not paying me attention yet.
Wait, we get one hernia
You listen to me?
No, MBBS fine.
Questioning. An indirect hernia must come through the deep inguinal ring. Yeah? Whereas a direct does not. It goes directly straight through the posterior wall into the canal, through a weakness or bulging of the girdle, the fascia transversalis. Yeah? You with me? And the direct hernia comes through a triangle. You know what this triangle is called? The same lady. A direct hernia comes through a triangular area through the posterior wall. The same lady. You have to understand what is this area called. Mr. Gardner showing you what is that triangle called? Hessel's back triangle. And can you define what is Hessel's back triangle for me? What are the boundaries of Hessel's back triangle?
Erectus abdominis muscle medially.
Medially inferior.
Because remember this rectus now.
Immediately is the lower 5 centimeters of the rectus abdominis.
Medial as well.
That's medially.
Is the inferior epigastrium.
Laterally, you're going to have the inferior epigastrium. Yeah?
And then inferiorly the ligaments, the inguinal.
And the base is formed by the inguinal ligament. This is the triangular area. That is the Hessel's back triangle, which you must understand. You get me? No, I don't know if we can show you this down here. So. You can magnify down here so from the breathing. What I'm showing down here is the posterior abdominal, posterior part of the inguinal canal. Yeah? And there's always a depression there, which I magnify by pressing. You see that? You can show that this depression there. You have to lift up your whole specimen to show you. Yeah? There's a triangular depression area here through which direct current occurs to the posterior abdominal wall. And that area is referred to as the pyriform fossa. The pear shape to you. Look kind of pear shape to you. And if you look here, so. Yes, yes.
Oh, that's good.
Through this pear shape here, the lateral boundaries. The lateral boundaries there. Sometimes they ask me to put that in the example.
Of the
Please, guys.
girlfriend. That's crazy.
And my lady girlfriend in the black, you're going to be experts. What is this area here? What is the structure? You see, it's forming the lateral part of the pyriform fossa. You see that? Should I pay that? Is he indeed black? I tell you, what is this? You see? See, being elevated. And that is not equivalent to the example. Anybody know what this is? That is the inferior epigastric artery.
Wow.
Somebody said that. Just to show your face in the blue. Breathe. And see it. Become white coat. De-stress in the exam.
Okay, so that's the lateral wall of the isosceles triangle. Okay?
It's okay.
All right, great.
No, I want to take it. I'll wait. Sleep.
Leave it alone. Just like crazy.